Otitis media is characterized by fluid in the middle ear and is often associated with a variety of inflammatory or infective processes that may be bacterial, fungal, or viral, and they often follow upper respiratory tract infection or allergies. Though anyone can get it, the peak incidence usually is between 6 and 15 months. Middle ear effusions can also precede or follow acute otitis media, and this is a buildup of serous fluid in the middle ear without any related inflammation, and they can actually persist for weeks to months after the infection. Bacteria is the most common culprit for acute otitis media, and oftentimes it occurs in conjunction with a viral infection. The most common bacteria found are Streptococcus pneumoniae and Haemophilus influenzae. Smoking and narrow eustachian tubes can also increase your risk for developing this infection. A lot could really be going on in this area, so other associated symptoms like headache, drainage, nasal congestion, sore throat, mouth pain could also indicate a previous or current upper respiratory infection. We may also see tender frontal and maxillary sinuses, as well as some lymphadenopathy in the cervical and posterior auricular lymph nodes. All these would likely again point towards a previous or current upper respiratory infection. One of the required findings to diagnose acute otitis media that you'll want to verify is the presence of a bulging tympanic membrane plus or minus the erythema around it. This, alongside the myriad of other symptoms that were mentioned previously, will help determine the cause of the symptoms, the severity of the infection, or whether it is just acute otitis media or a simple effusion. You may consider getting a CT of the sinuses if the patient has frequent or recurrent chronic otitis media, or if intracranial or intertemporal complications are suspected, and an allergy test may even be indicated for other potential causes. Now, studies support the potential benefits of waiting 48 to 72 hours before administering antibiotics in patients with mild symptoms at a minimal risk. And in terms of pain, NSAIDs are commonly prescribed. And for antibiotic treatment, we'll be looking at the same medications for both children and adults. And this is the first line treatment is amoxicillin clavulanate. For adults, we're looking at 875, 125 milligrams BID for 5 to 7 days. And this depends a little bit on severity. And azithromycin and or doxycycline are other options if there is a penicillin allergy, for example. In kids, 90 milligrams per kilogram per day of amoxicillin is what's recommended, or a third generation cephalosporin or azithromycin for those with an allergy. And in children 2 years old, or under 2 years old, that have symptoms for at least 72 hours, these are the ones that are going to benefit the most from immediate antibiotic therapy. The duration of treatment for these kids should be at least 10 days, and when they're older than 2, we can look at shortening that between 5 and 7 days like adults. Those who don't respond within 72 hours should be switched to a second-line treatment, and obviously if that doesn't work, then we'll be referring them to an otolaryngologist or to be admitted to the hospital.